A 34-year-old woman presents with confusion, drowsiness, and headache. The patient's husband says her symptoms began 2 days ago and have progressively worsened with an acute deterioration over the past 2 hours. The patient describes the headaches as severe, localized to the frontal and periorbital regions, and worse in the mornings. Her review of symptoms is significant for a mild low-grade fever, fatigue, and nausea for the past week. Past medical history is significant for HIV infection, for which she is not currently receiving therapy. Her CD4 T cell count last month was 250. Her blood pressure is 140/85, heart rate 90, and temperature 100. On physical examination, she is conscious but drowsy. Papilledema is present. No pain is elicited with the extension of the leg and the knee joint, and the remainder of the physical exam is negative. Lab findings, including blood and urine cultures, are ordered, and a non-contrast CT is negative and is followed by a lumbar puncture. CSF analysis shows elevated opening pressure, low glucose, protein is elevated, and her cell count is 20, elevated. Which of the following additional findings would most likely be found in this patient? So this question, once again, so this is a straightforward question of meningitis. All you need to be able to recognize is her risk factors. So she is a known case of HIV. Her history is significant for HIV. She is not receiving therapy. Her CD4 count was 250. So what organisms would predispose a patient to meningitis in this case is what we need to figure out. So cryptococcal meningitis is a common opportunistic infection in HIV-infected patients. The organism is Cryptococcus neoformans. It is also seen in those exposed to pigeon droppings. So that is very important to associate with cryptococcal infection. It's associated with pigeon droppings. HIV patients with a low CD4 T cell count are particularly prone, and CD4 T cell counts of less than 100 are patients who require antifungal prophylaxis with fluconazole. Characteristic clinical findings, you all know this: headache, nausea, vomiting, altered mental status, raised ICP in the absence of meningeal irritation. CSF will show elevated opening pressure, increased cell counts, low glucose, and high protein levels. So typical of any fungal CSF finding. Typical CSF analysis for cryptococcal is the India ink staining of CSF, serum and serology for cryptococcal antigen, and fungal culture. Okay, so India ink staining is our key here. On India ink staining, the characteristic picture is of encapsulated yeast cells. The capsule is visible as it does not take up the stain, and this may be used as a quick diagnostic tool for cryptococcal meningitis while serology and culture results are being awaited. False negative is highly likely with a microscopic diagnosis, and serology is the most sensitive and specific test for cryptococcal meningitis and should always be used. So the India ink staining is not the most definitive test, but it is a good initial test while you're awaiting your serology results. Okay, so this is what the India ink staining looks like. And so this patient is an immunocompromised woman with altered sensorium, fever, signs of elevated ICP, CSF findings suggesting a cryptococcal meningitis infection. So a definitive diagnosis is made by finding of encapsulated yeast cells on India ink staining of CSF. So if India ink staining is positive, it does give us a diagnosis, but there is a high rate of false negative. So if it's negative, we still wait for our serology results, which have a higher sensitivity and specificity. Okay, so the key here would have been to recognize the diagnosis of HIV and the CSF findings.
Thanks for watching. Please give a thumbs up and subscribe for more.